Okay, so we have discussed all sorts of different types of wounds and skin conditions, things that put our patients at risk, and things we're going to monitor for, things we're going to do to prevent injuries and wounds. So now we're going to talk about what we're going to do about them. So this is going to be applicable to your wound care lab. So that's where you'll be putting this all into practice. So you are not going to be able to always just walk in and say, oh, this is what type of wound that is, and that's what I need to do about it. It's not always going to be that easy. Remember, all patients are different. All healthcare providers may be different in how they want to treat the wounds. Different facilities may have different wound care protocols and supplies available, and then also may have different ancillary staff that do different things to take care of the wounds, like wound care nurses. Not all facilities are going to have wound care nurses. So make sure that you customize to your client's needs. You utilize the resources and teams you have available for you at your facility, and you always follow the order. Remember, when you are changing a dressing, you need an order for wound care. So what we're going to be going over is basically a generalization and an overview of all that. So remember, follow all parts of the order. Prior to giving care and changing a dressing, you may need pain medicine and be able to administer that to your client, because some of these dressing changes are going to be very uncomfortable. You want all your supplies. You need to confirm whether the dressing change is sterile or not sterile. We used to do a lot more sterile dressings, but they have shifted to more of a non-sterile environment, but we do still want it to be as sterile and clean as we can make it. Remember to hand hygiene before starting. Think about what PPE you might need. If you're going to be irrigating something and you're splashing something into a bloody wound, you're probably going to want goggles and a mask and a gown and all the protection that you would need, thinking about what you're doing. If you're changing a dry dressing, you may not need all that. So when we are going to assess our wound, let's talk about some of the things that we're going to assess. First of all, location. I'm going to stop sharing for a few minutes. So location, we're going to look for where is that wound at. And we want to be exact with that. So midline sacral wound. And remember that we want to use our anatomical positions. So posterior, anterior. This would be more medial. This is lateral. So use those terms. Approximation. So another wound here. So here, these edges are approximated. They are touching each other and there's no gaps. If it is not approximated, think about something like this wound. This wound is not approximated, the edges aren't touching. Is there pain present? What is holding the incision together? So here we have sutures holding it together. Is it staples or dermabond, steri strips, which is just like the little pieces of tape? Is there drainage on the wound or on the dressing? How much? And we go small, moderate, large, copious would be our, or scant. If there's just a tiny amount, we may say scant. And then what color is it? So remember serous, so like clear yellow, sanguinous, which is bloody, serosanguinous, which is kind of a mixture, purulent, which is the more pussy looking, white or yellow, and does it have a smell? We want to assess that peri-wound area for any redness, edema. So like this wound, we have a little bit of, it's a little pink around the outside, and you can tell it's a little edematous. But remember, we're going to have that inflammatory process present when we've got damage to the tissue. So a little bit around the edge is to be expected. Now, if it was red heat radiating off or streaking out, that would be definitely a sign of infection. So we do want to assess for that. Is there a rash present? Is there, which you could get just from the adhesives? Is it pale? Because remember, we don't want it to be pale because that means there's not enough blood flow. What are some signs of healing that we have? So like this tissue, this red beefy looking tissue is like granulation tissue that's healthy. It's, that easily, it's very highly vascular. That means all that blood's getting there and starting to heal up. So that's what we want there. So when we're looking at an open wound, so we'll go back to this guy here. Remember, it's healing by secondary intention. So it's healing from the inside out instead of primary intention like here, where it's closed on the outside and then it's healing on the inside. So where is it at? Is there pain present, drainage? All that's the same. So let's talk about the wound bed. So staging, remember staging is only used for pressure injuries. How do you know if it's a pressure injury? If it's in an area where there's pressure, right? So was there a medical device there? Have you got a medical device related injury? Is it on a bony prominence? That's what we want to look for. So we want to stage it. So remember stage 1, skin's intact, but it's red, non-blanchable. Stage 2, you've got generally a small crater, just the dermis is involved. Stage 3, you're getting down into the subcutaneous tissue with a deeper level. And then stage 4, you've got bone, muscle, or tendon showing. And remember, you have to be able to see to be able to determine that. So the wound bed, how size is it? Remember, length is always head to toe. So length, width, always head to toe, and then width is across. So you go from just the furthest down and then the furthest across. For depth, we're going to use a sterile cotton tip applicator and put into the deepest part. I'll show you here. So we'll use a sterile cotton tip applicator and we'll go into the deepest part. Just use your fingers as a measurement just to where it's flush with the skin. And then this would be the depth. Same with something like this. If you were measuring depth, you would just go into the deepest part and then stop where you're level with the skin. And then and then you measure, use a tape measure to measure in centimeters. What does the tissue look like? Is it red granulation tissue, which is this beefy, good looking tissue? Is it patchy yellow? That's not good. That's not what your skin should look like in a healing wound. So what does it look like? Black or leathery spots. This is an unstageable pressure injury to that ischial tuberosity there. So it's black, leathery eschar over top. We can't do anything to be able to assess that. And then here, like on this one here, which is that greater trochanter, we've got slough. So that yellowy brown, same as in here. So we can't stage that if it's showing that we can't get down to the bottom. Anything that would be pale, like if there's pale tissue where we saw this granulation, if it was like a pale color, that means it's not getting the blood flow. It means poor perfusion. We'll assess for tunneling. So that would be like here, where that's going under the bed and it's going back into here. So that's how we would tell there. Undermining would be that there is just like this, where you can see it's going underneath of the skin here. And then the epibole would be if this is curling in, this tissue starting to curl around the edge. And then lastly, we want to assess the peri-wound area. So we want to look for signs of infection, red streaking, heat, inflammation, swelling. We want to look, is it a good color? Is it getting adequate blood flow? Remember, we don't want it to be too dry or too wet. We don't want signs of maceration or desiccation there. And we want to make sure our wet to dry dressing is staying inside the wound and not getting on that peri-wound area for that reason. Oops, sorry about that. Okay, so when we've got a closed surgical wound, and we're doing the assessment, remember, we're going to look for, is it approximated? We are going to see what it is closed with, like this is sutures, is it staples or steri strips? We may want to, depending on your hospital policy, you may have to count and determine how many there are. So when you're cleaning these closed surgical wounds, you may clean with sterile saline or sterile saline solution. And so you would want to pour it and let it, and you would want to squirt from top to bottom. You can also use your sterile saline syringes that you would use with your IVs also, and just kind of gently squirt, let it roll away. And then you will use a dry 4x4 to dry, top to bottom, toss it, get a new 4x4, top to bottom, toss it, get a new 4x4. Make sure that you are always using a clean 4x4. Make sure that you are following the order. We want to remember that orders are going to be specific to the healthcare provider, so make sure you're following the order of what you need to do. If you have an order to cover it, then make sure that you do not window pane your dressing. So hold on, let me get some tape, and I'm going to show you what I mean. So window pane would be just like what it sounds like, would be creating a window pane with your tape. So it would be a piece of tape across the bottom, on this side, on this side, on this side, and then leaving that middle open. We don't want to do that. We want to always tape across the middle, so no window painting. So what we will do is go from top to bottom, left to right. So we would tape here and across, and then overlap here and across, and then here and across. So we would do an overlapping from top to bottom, left to right with our tape. So if there is a drain, you can clean around that drain site with your sterile gauze and saline, pat it dry, same as you do with the incision, always get a new one. And then you can use a drain sponge. Let me go back to sharing my screen again. Okay, so this is a drain sponge. You see it's got a pre-cut thing so that you can put it around the end of the drain. Please do not cut a 4x4 because it's got little strings. If you cut it, it's going to create little strings and things that could go into your incision. That's not good. That's not what you want. So also don't put tape on your drain. It creates a mess and can end up dislodging that drain while people are trying to change the dressing. And then for documentation, you would document all those things that you assessed about the wound. And then you would also document how did the patient tolerate it. So do not say it was well tolerated. You would document what the patient reported. The patient reported no pain with dressing change, or a patient reported pain 7 out of 10 after pre-medication with pain medication. Okay, so now when you're caring for an open wound or a wound that's healing by secondary intention, like this open unapproximated wound, or possibly this wound here, we're going to do the full assessment just like we've talked about, and then measure it as we've discussed. You'll have to confirm per your order whether you're doing it's sterile or non-sterile. So please make sure and confirm that. Even if you're not sterile, you still want it as clean as you can. So make sure you got all your PPE on. And we're just going to kind of go through this process a little bit. I'm going to stop sharing. Okay, so when you're doing it, after you've measured it and you've done your assessment, and you're ready to take care of it. So first of all, put on your gloves. You would remove the old dressing, toss it away, do any assessments you needed to do on the exudate that was on it and all that, and then change into clean gloves. After you've removed the old dressing, switch out for clean gloves. Do hand hygiene. You want it to be as clean as possible. So first up, you may need to do a culture. So when you do the culture, you want to have cleaned first. So when we're cleaning, you will clean, you want to clean from the inside to the outside. So irrigating, let it drip down, and then same as you did before, always new sterile 4x4s, top to bottom, dry out. New one, top to bottom, throw it away, get a new one. So then we're going to use the Levine technique for obtaining cultures. So if you need to get a wound culture, you do need an order for that. If you think it's needed because there's a new smell or there's exudate that is now purulent and before it was serous and you believe a culture is needed, then you call and get an order for that. So after you've cleaned your wound, then you would be ready for the culture. You don't want the dirty gunk that's in the top. That might be stuff from the skin and things like that. You want the bed of the wound. So after you've cleaned, you would label date, time, and initial. You would check your 2 identifiers with your patient, make sure you have the right patient. Label date and time your tube to get the culture sample. So your wound cultures come in these sterile packs. They'll be closed and be sterile. So you've got this inside, you see it's not broken and it says it's sterile on it. So that's what you would label and send to the lab. And then you've got your pipette. So the end of this is sterile. It came out of my sterile package. It hasn't touched anything. It's sterile. There's nothing on there. You do want to wet the end of it with some normal saline. So you can squirt it with sterile saline to get the end of it so that it is wet. The bacteria is going to attach to the end of that better if it is a little bit wet. So then you would apply gentle pressure into the bed of the wound, swab, and then you would put this back in the tube to be sent for a culture. And then this is date, time, and initialed, and you can send it off to lab with your requisition. All right, so now when we're going to pack our wound, if this is not a sterile dressing, we do want to, anytime you feel like your gloves, just go ahead and change gloves as much as you want to. The cleaner, the better. So you've got your clean gloves on, you still want it as clean as possible. So you want to keep everything as clean as you can. And so we've got, when you open up your gauze, the inside, this is now sterile. The inside of this is sterile. You use your sterile saline and you can pour it right onto that surface there, just directly onto it, onto your, I'm going to try not to get my computer wet, onto your gauze. Okay. So now that is saturated. So I don't want this to be, see how wet this is? Oh, I'm going to make a mess. Okay. So I don't want it this wet. Okay. What I do want is for it to be moist. So, okay, so you want to wring out the excess moisture, okay? You don't want it completely dry, but you don't want it that saturated either. It's just like kind of a loose. You want it fluffy. So then you would take your gauze and open it up. You don't want it all like, you don't want to pack your dressing with it folded up in a ball. Like, so you're going to unfold your gauze, get it all the way out. Because remember, the point is to remove bacteria and dead tissue. Remember, this is a form of debridement. So, and then you would loosely pack it in here. So you don't want it to be, you don't want to cram it in there as hard as you can. You're going to hurt your patient for one thing, and it's not going to really serve the purpose. So you want to loosely pack it in there. And then we'll do the same thing with this other one. You want it to cover all the interior surfaces of the wound bed. You do not want it touching that peri-wound skin, all that skin that's on the outside of the wound. You want that skin to stay protected from the moisture so it doesn't get macerated. So we'll just loosely pack this in here. Sometimes if you've got some tunneling and things, you can use a sterile Q-tip swab to kind of push it. Like, let me switch wounds here. Like with this wound here, if you were trying to get into where it is undermining, you can use a sterile Q-tip and gently kind of put it in there. You can put it into some of the tunneled areas as best you can, following the wound care instructions. So this one, you can kind of tuck it, use our Q-tip here and kind of tuck it in so that it's touching all the surfaces. I'm gonna go ahead and switch over to this wound, and then we can gently finish packing that with our loosely. So that's loosely packed. It's not coming over onto our peri-wound area. You will typically then put a dry gauze over top. So that may be a gauze or that may be a ABD pad, which are thicker and they absorb more. What that is going to be determined by, and there's different sizes. This one's really big and not, it's too big for this spot, but something like this would be the appropriate size. Or it may just be a 4x4. Usually you're going to determine that by how much exudate and drainage that you've got going on. If you have something that's draining a ton, get your ABD pad for your top pad. If it is just draining a tiny bit, you can just stick another thing of 4x4s on there. Again, we're not going to window pane. We're going to go top to bottom, left to right with our tape. So let's see. So we're going to go top to bottom, left to right. And tape on here. Top to bottom, left to right, fully covering everything. Okay, it's kind of hard to do this upside down, but and while holding this up. Okay, and you can also, you could pull that and tear the tape. Okay, so top to bottom, left to right. We've got everything covered, right? So then we need to date, time, and initial. I'm not going to get my pen out and write. Now this wouldn't be optimal since it's like at this person's area where it could get. I'm not going to get my pen out and write my initials real big across the top of this, right? What you can do is write on a piece of tape, date, time, and initial. And then tear that piece of tape off and pop it onto your dressing there so that they can, so that everybody knows when it was changed. I'm going to go back to sharing my screen again. The other thing you can do, sometimes people's skin gets super irritated from all of that tape being on there all of the time. So one of the things that you may see, especially with abdominal wounds that are at risk for dehiscence and evisceration there, or laceration, anyway, it is the Montgomery straps. So they have some, let me get my pen. They have some adhesive, but it's out towards the outside, which is away from that peri-wound area where you've been putting tape at. And then they have straps over the top, and you'll be able to see these in Wound Care Lab. So there are all sorts of different types of dressing that you're going to see in the hospital setting. Again, sometimes these just depend on what is available there at the facility. So hydrocolloid dressings are typically used with mild to moderate drainage, shallow. They are used often for skin tears and things like that. They can be left on for 4 to 7 days. Also, the transparent film, like an opsite, you may see in use for something very shallow with minimal drainage, also for 4 to 7 days, those can stay on. Hydrogel is used to keep moisture in. So it's used topically if something's dry and you need to keep the moisture in there. A foam sponge is highly absorbent. It's used for large to copious amounts of drainage. It can be changed daily to weekly, depending on the amount of drainage. and it wicks moisture away. So one of the things I always think about is around trach collars, where you see all the copious oral and respiratory secretions coming out around them, is these foam dressings that go there. Also around peg tubes, you might see them around drains as well. Silver is antimicrobial, so you may see silver impregnated creams or dressings used for wound care to prevent an infection or treat an infection. They only are supposed to be used for about 2 weeks to prevent resistance to it. You also need to make sure your patient doesn't have a silver allergy. Calcium alginate, it comes from seaweed. It is engineered and is highly absorptive and helps with hemostasis. It does smell a little weird. I have seen that used in the cardiac catheterization lab. Whenever they stick that artery, they can use something like that to help to create hemostasis of that artery. Gauze may be used wet or dry. They don't really barrier against bacteria, but they can help pull out unhealthy tissue and pull out bacteria if it's done appropriately as a wet to dry dressing. Collagen is typically used for chronic wounds. It helps to stimulate new cell growth. Composites is when you see two types of dressings put together. Hydrocolloid fiber would be like Aquacel or Aquacel AG. That is like a hydrocolloid, but also has that silver with it. It is 30 times more absorbent than the calcium alginate. So it is used if you have a lot of secretions. And then you also sometimes will have an antimicrobial dressing to prevent infections. So staple and suture removal. Let's talk about that real quick. So we have here let me get my pen. Okay, this is your staple remover. And you'll be able to practice taking out staples in wound care lab. And then this is your suture removal kit. I'm gonna stop sharing for a minute. Okay, so your staple remover, it's like a little pincher here. When you're removing the staples, you will put the two little fingers there. They kind of scoop underneath the staple. Here we go. I'm like, surely I've got some papers that are stapled. Because it really is like a staple in your skin. So you just kind of, these two little teeth kind of go under your, I don't know if this is going to work. We're going to try though. We'll go under your staple, okay, on the skin, and then you just squeeze it. And it pinches that staple up. Now my papers are not going to work as good. You can see it created like a little M with my staple. So it bends it up, and in skin, because skin is soft, it does kind of pop out and pinches that skin. Sometimes if they've been in it for a long time, you may have to like a little bit. And then with suture removal kits are going to come in with, they come with tweezers and they come with scissors. So when you're getting them out, like on my arm here. Try to prop this on my shoulder. Okay. And do it backwards. So we'll see. So, oh, here we go. This is better. This guy has sutures. Okay. Sorry. Okay. This is going to be easier. Okay. So with your non-dominant hand, you'll hold your tweezers and you'll get the end of the string and pull up. Now you're going to cut as close to the skin as you can. You don't want to cut your patient, but you would go underneath. Then you would go underneath that suture and cut as close to the skin as you can. The reason for that is because when you pull that out, remember this has been outside the body, and then it's going to go inside as the suture comes out. And so as little bit has been exposed is the better. So you just pull up, get close to the skin with your scissors, and you clip, and it pulls right out. You'll be able to practice that in wound care lab as well. So if you're left-handed, your tweezers are in your right hand. If you're right-handed, tweezers in your left hand. Scissors go in your dominant hand. You will need to follow the order. You may be cleaning the wound ahead of time, and you would do that the same way we talked about earlier. You may need to apply steri strips. Sometimes they'll have you not remove every one, like they'll say remove every third suture and replace with steri strips, in which case you would count 1, 2, 3, remove this suture, put a steri strip there. 1, 2, 3, remove this suture, put a steri strip there. And that's how you would do that. So you need to follow the order with those. I'm going to share my screen again. Okay. So drains. When we're caring for a patient with a drain, the purpose of the drain is to drain fluid away from the wound, decrease pressure on that wound. You can also use it to measure output correctly. Whenever you're measuring, you want to measure into a measuring cup so that you don't want to just like eyeball the drain and be like, oh yeah, that looks like it's around 30 cc's. You want an exact amount because that's going to help us gauge how well this is healing. So remember, you need your PPE on when you're messing with all these body fluids and drains. Let's talk about a few different types. So your Penrose drain, this is typically used in abscesses and in small tissue that's soft and flexible and empties by pressure gradient. So the fluid's going to go from an area of increased pressure inside the tissue to the decreased pressure in the atmosphere. You can't document output with these. So it's going to empty directly into a dressing. So you would have a soft dressing on top of it. So an example of this is here in our picture. See, this is a soft, flexible tube that's coming out of this hand here. You would have a dressing over top of this, and that would drain directly onto the dressing. T-tubes are used for bile after gallbladder surgery. That's what we have up here in this picture. We don't see those as much anymore. What we do see a lot of is JP drains, and that's what we've got in this picture here. They're a little bit hard to see, but the JP drains have a bulb on the end, and if that bulb is compressed, just like if you had a water bottle that you compressed and then you let go and you had your hand against it and it doesn't open, it creates suction. So that compressed bulb creates suction. So with those, you just to measure, you just open up the little thing and you squeeze it out, and then you would follow the order as far as compression goes. But remember, if it's ordered to be compressed, you have to watch that drainage, because if it fills up, then that bulb is full and it's no longer creating that suction that's needed. Hemovacs are just another type of a suction type of a drain that we don't see as much. The autologous is going to be typically used immediately after surgery, and it drains blood out and then it reinfuses it back into the patient. It is measured as output and then input as well, and requires additional training. You don't see that very often either. It's usually done immediately post-op. Next up, we have wound vacs. So wound vacs you will see at the bedside. They are for moist wound environments and create negative pressure. They stimulate increased blood supply and help to build granulation tissue like we want, like this red tissue. It helps to increase that blood supply and build up that granulation tissue. They can be irrigated, but are typically just left on in place with the negative pressure and are typically used on open wounds that are healing by secondary intention. They remove excess fluid. They can be used to treat acute or chronic amounts and used with things that are draining a lot or are very slow to heal. It should not be used if somebody is actively bleeding from that wound. A little bit of blood, like sanguineous dressing coming or sanguineous fluid coming out, is okay. If it is constantly pulling out a full stream of blood, that's not okay. So also exposed organs would be a contraindication. If there are blood vessels showing, nerves showing, or malignancy, that would be bad. Obviously, we don't want to create negative pressure or traumatized exposed organs, blood vessels, or nerves. With malignancy, we're pulling blood flow, we're increasing blood flow. So we don't want to do that to a cancerous area because that could cause that cancer to grow. We don't do it with dry or necrotic, or if we know or suspect that there is a fistula there. Typically, the dressing and canisters are changed every 72 hours or as needed or ordered. They run with 125 to 150 milligrams of mercury suction, typically. You, as the bedside nurse, will, I didn't erase my drawings, hold on. Okay, so your canister would go in the side here. And what you typically do is mark where the drainage is. If you see that the canister is filled to here, then at the end of your shift, you would mark it at the top of where that drainage is. So that then the next nurse would measure how much they got on top of that. And that's how you would measure it. It does have foam underneath. So basically what you need to do as the bedside nurse is you need to know how to care for, how to measure it, how to troubleshoot, how to, and what you want to look for as far as leaks go. It should be suctioned down. And then lastly, hyperbaric oxygen therapy. And hopefully you'll see this at your wound care rotation. It increases the amount of oxygen dissolved in the plasma in the blood. So it increases oxygen at the tissue level to deliver more oxygen to those wound care areas to promote healing. Remember that it is highly flammable. And as far as treatment for your patients and who's at risk that you need to watch out for is people with glycemic imbalances or seizures, because just like if you've ever been scuba diving before, then you may know that you have to adjust to the pressure when you're going down and up. And it's the same in this hyperbaric chamber. It changes the atmospheric pressure that patient's experiencing. And so that takes time and they can't just cut it off. It'll make the patient very sick. So people who are at risk for glycemic imbalances or seizures or things like that, where they may need to do an abrupt stop, may not be good candidates for this. So that is going to conclude this last part of our tissue integrity recordings. This is for your lab portion. Please let us know if you have any questions, and I hope you have a great experience in lab and in your wound care rotation.